This podcast is discussing which punch size I use, because this is a very common discussion that I've heard from people asking me in consultation, which punch size do you use? Because I heard you must use only this size because it will cause scarring, or I will only use this size because of some other reason. And so a lot of it is marketing, and you just want to know clinically what I use. So punch sizes are basically the diameter of the punch that is being used to excise the graft through FUE, hair transplant surgery. It's the diameter. Now, there's all different types of punch sizes. There's different punch shapes, whether it's an inner bevel, an outer bevel, or middle bevel. But I'm talking about edge to edge where the harvest is, what I use. So my workhorse is a 0.9 millimeter. The reason for it is that it gives me the most flexibility. It gives me the largest size to easily harvest a graft in most cases. In African American, I may go to 0.95. In certain circumstances, I may just go larger. Now, if you said, well, why would you go larger? Is there a problem with scarring with that? Well, actually, what was interesting is Jim Harris did a study where he looked at 0.8s, 0.9s, 1s, and he looked at the degree of hypopigmentation or scarring caused by different size punches, and he found that actually all of them created very similar degrees of scarring. So that is why I don't think it matters as much to say you must harvest with something in a dogmatic fashion. The problem with going really thinner on the punch is that there's a higher chance of transection and possibly compromising graft survival when you're going super thin, because the grafts are so slender. Now, is that proven? Not necessarily. I would say that if you go super slim, there's more of a risk of those things. So I don't typically go down to like a 0.75, 0.8. I may go to 0.85. And then when would I go smaller? So I would go smaller with very straight grafts that don't have a lot of curl to them, where I'm trying to harvest off a particularly difficult, I wouldn't say difficult, like a complex family. So it's called in vivo graft splitting, which is another podcast I did, where essentially what it means is I've got to split off one graft from another, and the spacing is so tight that I'm worried about transecting, and the patient has a lot of these complex graft families. Then I may go down to a 0.85, for example. So these are just the thought processes, and hopefully this answers some of your questions when I've been asked this. I don't know why my patients have become so savvy. They're asking all these detailed questions, but I thought a podcast on this subject would help you understand what I do, why I do it, and how I think.